visto al doctor Garson, tiene un currículum realmente espectacular. Solo desde el punto de vista cardiológico, que es con lo que más nos interesa hoy, el doctor Garson ha sido presidente de la American College of Cardiology, ha sido decano de la Facultad de Ciencias, decano de la Facultad de Medicina de Virginia, jefe del servicio de cardiología pediátrica de Houston. Estaba comentando ahora que él ha tenido el privilegio de estar por la mañana con Pública y por la tarde con Debaji operando en el mismo quirófano, lo cual para los que nos hemos conocido sabemos que es una experiencia realmente inolvidable. Últimamente él trabaja mucho en problemas de gestión de programas de salud. De hecho ha sido miembro del panel, del equipo que ha diseñado la reforma sanitaria de Estados Unidos. No está completamente de acuerdo con cómo ha quedado, como han tratado los políticos. Y tiene un programa de tratamiento de pacientes crónicos con insuficiencia cardíaca, que es el programa de la ley, que es el que, bueno, se viene a presentar hoy aquí. And also he's here, the real reason he's here is because he's trying to pass a second exam of the paella cooking.
I failed the first one, but I failed it on purpose so I could come back.
And he will try again this after. Well, and the other thing is, he's a friend of mine. He always, siempre lleva majarita, que él no iba a estar solo, y bueno, yo llevarla con él. He always wear both ties. And thank you to be here.
Well, thank you, sir.
No,
thank you for being here.
And he's a friend. We are home friends.
Okay.
And I hope that we can ask many questions.
Oh, sure.
Okay?
And a few minutes, they're what?
Well, they need to work.
See.
Not too
Seriously.
okay. No, system. How to work.
Okay. I very much appreciate all of you coming. I will please, even this early in the morning, you will go to sleep if you don't ask questions. So please, interrupt, help, ask questions. Don't be shy, because if this is a lecture, everybody will sleep. But fortunately, the lights stay on, which is good. No, because we're going to talk about. Come on, guys. I'm sorry. We're going to talk about a program called Grandaids, and it started with an idea that has evolved. The idea started out literally with grandparents helping to take care of patients, and it has evolved. It turns out, at least in the United States, that it is not legal to require someone to be a grandparent. We have these laws about discrimination in the U.S. We have age discrimination. This is grandparent discrimination. You're not permitted to require someone to be a grandparent because it discriminates against people who don't have grandchildren. Like me, I have children, I don't have grandchildren yet, so I could not be a granddad. That has evolved, and it has evolved such that we have plenty of people in their 20s, 30s, 40s, 50s, 60s who help to take care of patients with the goal of really access to providers to free professionals to do what they have to do. This whole idea is about leveraging, is about using well-trained, and we'll talk about what that means, well-trained lay people who then help nurses, who help doctors, but leaving then the nurses and doctors to do what they have to do. The idea is to reduce unnecessary emergency room and primary care visits, but importantly here, our goal, what we'll talk about, is managing very specifically patients with chronic disease and keeping them out of the hospital, keeping them at home. Certainly it's about educating. It's about the term that has been used a lot in the U.S. is bending the cost curve. It just means making care cheaper but better at the same time, we hope, and creating jobs. So this is somebody, Grandade is somebody who has had a curriculum in medical care, and depending upon the country, and we're talking with about 15 different countries, so this is not a U.S. program. There's actually there are more programs outside the U.S. than inside the U.S. But in the U.S., it is somebody who is a nursing assistant, but it doesn't have to, you have people, you have auxiliaries, you have people here who have some degree of medical training. Some degree of medical experience is helpful. They can be lay people. We would rather they have a little bit of medical experience. What we found is that if you take, and I did not introduce Donna Green, who's right here, who really runs Grandades and who does all the teaching and all the manuals. If you take lay people, and Donna took 30 lay people in Texas and tried to train them, what we found is they very much like to take care of their own family, but all of a sudden they don't like to take care of somebody else. And so there is a certain screening process of nurses, nurse aides, people who have taken care of patients that at least has us saying, gee whiz, maybe they demonstrated the ability and really the joy in taking care of somebody else rather than just their own family. In France, they're using retired nurses as Grandades. So there is a real flexibility in who these people are, and it's entirely related to what works here. They are usually paid. The reasons for that, as you'll see, we want them to be with the patient every day for 5 days at home. This helps to make that happen. Volunteers may decide they want to go shopping. So they're not paid a lot. They're paid at about the minimum wage. We were talking last night. It's about 7,500 euros per year. It's that level. They don't get paid a lot, but they are paid. And there are about 5 to 6 Grandades per supervisor. Now, a supervisor, they report, Grandades report to somebody. Depending upon where it is, most of the time, the Grandades make no decisions and communicate with the supervisor for every decision. So as you'll see, when they go home, they actually put the patient and family on television, on video, back with the supervisor every time. The supervisor then can say, stay home, or come to the clinic, or change the Lasix. There are some, we have a program in Indonesia where there are actual protocols. The Grandade can follow a protocol that says if the temperature is greater than 38.5, give Panadol. So we've done both. My understanding of how it would work here is that every decision would be supervised by a nurse. Rather, so it would look like this. And again, depending upon where in the world they are, They can either be supervised by physicians, nurse practitioners, or nurses. Our preference is a nurse, and you'll see why in a minute. And we do a lot of different things, but I'd like to concentrate on the cardiac patient. We have a manual that Donna and her team has prepared for cardiac disease, heart failure, myocardial infarction, coronary bypass, and stents. It's about 300 pages for the grand aid. And the grand aid, again, is somebody who's maybe high school, not university, but these manuals are written at that level, and then there's a patient education manual that goes along with it. Now, the nice thing about these manuals is they're written in Microsoft Word. They are changeable. Certainly, they're translatable. Someone asked a couple of days ago how many languages we've translated the manuals into, and we now are up to 5 different Spanish manuals. So there is a Mexican manual, there is a Puerto Rican manual, there is a Colombian manual, hopefully there is a Valencian manual. So we may have, and as you know, the idioms are a little different. So it's not that hard anymore to translate things. But it's not just a matter of translation. It's a matter of taking how you practice medicine and how you would want a grand aid to act with a patient and changing that manual to fit practice here. Not the US, not Italy, not Ireland, but here. And so that's really the first thing that happens. Is there's a lot of training involved, but we work with the doctors and nurses here to prepare a manual for both the grand aides and the supervisors that reflects how things are practiced here. Now, what do we do? Imagine someone with heart failure who is just leaving the hospital. Ideally, the grand aide sees the patient in the hospital, ideally. On the other hand, since they are visiting patients at home, they may not, just scheduling, it may not be possible to see every patient in the hospital. But the supervisor here would see every patient before they went home. This is probably the most important part of the whole program, is they see the patient at home the first day. So you hear a lot. There's 2 seats here, then there's 2 over there, folks, and there's 1 here. You hear a lot about seeing the patient within the first week after they go home, having a return for a clinic visit within 1 week. That's 6 days too long. You need to be seen the first day. Okay, so first day, and then daily for 5 days. Then it can go down depending upon the supervisor, physician, nurse saying, okay, this patient doesn't need to be seen 5 times next week. But the initial period is very important for 2 reasons. We'll show you what they do, but equally importantly, it's about a relationship of the grand aide and the family to, we've one of the grandaids in Virginia called this tough love. Now, I don't know what the Spanish expression for tough love is.
El amor de madre que te riñe, o igual te riñe que te prende.
So, you hug and you beat them. So, daily visits. Now, this doesn't have to be related to hospitalization. And so, in a hospital in Texas, April 1st, everyone with heart failure is getting a grandaid, whether they were just in the hospital or not. So it's entirely dependent on how the people here want to use these people, but it doesn't just have to be related to that admission. Now, as I'll show you in a minute, the results in Virginia have been successful. They've started with heart failure, and they've moved to patients with acute myocardial infarction who are just being discharged from the hospital. And in about 6 months, they're going to move to patients who have had coronary bypass and stents. So it's a progression. I will come back and talk to you about the other end, where we're also starting a program for patients who have asymptomatic hypertension and diabetes and obesity, using the same kind of idea of the very intense, tough love. And that's hypothesis. We will show you, we know this works in terms of medication adherence. We don't know whether the patient who's completely asymptomatic with hypertension, whether we can make that work as well. At home, they do 3 things. They assist the patient and family in getting started into a regimen of medication adherence and everything else. Daily weights, diets. I'll show you something in a minute about food labels, danger signs. Now, medication reconciliation has proven to be a very interesting issue. You know, the typical, when people say medication reconciliation, someone comes to the hospital, they're admitted, they usually are feeling terrible, so you ask their spouse, what medicines are they taking? And they bring the paper bag, or the plastic bag, or the 3 paper bags, and they say, here, okay? And then that becomes reconciled on discharge. So what were you taking when you got here? Well, Donna has been teaching in Texas, teaching supervisors to be supervisors and making home visits. And in the last 10 home visits, 9 of the 10 had important medicines the patient was taking on the way in, nobody knew about. Nobody knew about. So when you empty the medicine cabinets, what the granddad does, this is now at home. Get everything out at home, put it on one side of the kitchen table. Get all the new medicine, put it on the other side of the kitchen table. And then take out the iPad, turn on the video, send the video back to the nurse, and the nurse manages the medication reconciliation live. Okay, show me the Lasix. 20 milligrams. They were taking 10 milligrams. You didn't know that. What's that little yellow pill? So, you know, oh yeah, thyroxine. Gee, thyroxine. Sort of forgot about the thyroxine for the last 10 days. So, that medication reconciliation live is very important. And then the grandaids have questionnaires that the nurse prepares that the doctors really sign off on For example, we have a stop heart failure questionnaire. But it's changeable. All the questions can be changed. The idea is to have them in two sections. Emergency questions, less emergency questions. So you don't want the grandade, getting down to question 30 and having them say, oh, by the way, are you gasping? Question 30. You want, question 1. So there's the emergency questions, and as soon as they hit yes, they then fire that off to the supervisor electronically. We have a database in the cloud. I'm sure you have databases here. Ours certainly is usable. We have Vanderbilt University as our partner in really very good in terms of their forms, their database collection. But this form, yes, I'm gasping, gets fired back to the supervisor, who then sees it immediately and then goes on video with the patient every day. So, and we're finding that video connection between the nurse and the patient and family is very important. They think they're in the doctor's office. So they like that a lot. Now, these are different at the beginning. You'd think it should be a 3 or a 5 minute, gee, Carlos, please, count to 10, those things. The first time you have to see the dog. And you have to, so it takes a while. The television, oh, let me show you my kitchen. So it takes a little while, but after a while it gets pretty routine, and that visit is 3 to 5 minutes on video with the nurse. Now, this may or may not work here. We have we send patients home with heart failure and diabetes with rolls of, and they label the food, 250 calories per serving, 175 milligrams of sodium per serving, 140 calories. That's what a sugared Coca-Cola is, it's 140 calories. Everything else, and they label everything. The brand aid, the patient, the family, everything. Now, it doesn't take long for them to open the cabinet and see everything red. And they gasp, oh my goodness. And so you don't have to keep doing this. You can, but we have shopping lists where the grand aid will actually go shopping with the patient and try and find some things that are at least yellow, that are affordable. But the idea, certainly, we know that readmission in heart failure is usually one of two things. Too much salt or not taking medicines right. In that first week, those are the two things that happen. And so we want to try and manage both of those. Now, everybody has technology. Very important. And so what we want the grand aid to do is work with the monitoring equipment. If the patient goes home with a Bluetooth scale or a pulse oximeter or an automated blood pressure machine, help the patient get used to that. They are not electrical engineers, but they do help troubleshoot early. So they sort of, are the batteries in wrong, that kind of thing. There are monitoring centers around the world where there are nurses that make phone calls. The grand aid can be an extender of those monitoring centers for the nurses here. Yeah. Okay. University of Virginia, this was the first group to actually start collecting data. There are 62 patients. It actually started with about 90 patients. 23% said no. 23% said, I don't want anybody in my house. The usual data in the states with other programs are about 50%, so 23% is pretty good. And we think the reason for that is that the nurse supervisor goes and talks with every patient and family. But we ultimately had 62 patients, all class 3, class 4, discharged home within 60 miles. And the heart failure related readmissions went down 77%. That's basically one readmission for heart failure since January. Now, I understand you have very good results here already. So we'll have to see whether we can make it better or not. But we don't think we're going to do a lot better than 1 out of 62. Now, we know that there are other reasons people get readmitted to the hospital. And in the States and in England, they're starting to penalize for readmissions. So hospitals are having to pay penalties. The University of Virginia is facing $25 million in penalties over the next 5 years. So these are not small penalties, these are large penalties. And the measurement is all-cause readmissions, meaning if you break your leg, if you got sent home for heart failure, and you break your leg, you count. So all-cause readmissions become the thing that's very important, and we reduced that by 58%. A lot of programs do very well, 25% reduction, 30% reduction, 58% reduction, we think is a serious difference. Now, the other thing that's very important is that 91% of the patients were taking their medicines correctly at 30 days. Now, that to me is almost unbelievable. You know, that can't be. Well, those two are related, so it almost has to be. So they are taking their medicines appropriately. And this has given us, this has bolstered us with the idea that we may be able to take that same kind of very intense management with tough love and use it with the hypertensive, the diabetic, the obese patient to really give them somebody that is helping them to remember to take their medicine. You know, I'm going to actually move on because we probably don't need to do that. The training uses a train the trainers model, which means that the Brainwaves staff would come here and train your supervisors, and then train the Brainwaves, so that you can have 1,000 Brainwaves if you want. What we do is train the supervisors and work very closely with you to figure out, again, what that training material needs to look like. By April, it will all be web-based and easy to translate. But by April, it's not simply, you know, go read the computer screen, but there are exercises, there are group exercises, there are webinars that we should have this up and running by April. And someone did ask the question in the grid about lawsuits. I'm sure here, like anyone else, anybody can get sued for anything. So the answer is, of course, people can get sued. Now, we've been at this for 4 years and have not had one yet, but it's going to happen. The thing that mitigates this some is the grand aid's not making any decisions. The grand aid is the eyes and ears of the nurse. And the nurse gets to see the patient every day on television. So again, we've not had lawsuits, but we want to make sure that people know that these are not immune from anything, but we've not had one yet. As I've said, Vanderbilt is our partner in any of you that do a lot of research may know the REDCap system. It's a huge research database that we actually have somebody that works for grand aids at Vanderbilt that does nothing but create forms, translate forms, and get them right for different parts of the world. There are a number of places that we are talking with, including we're on our way to start a program in Scotland with the entire government of Scotland, so they'll be back up here. Rome, there is some possibility. We've had some conversations with some of the people. Let me finish here only by way of saying in the U.S., we have a group that we've applied for a grant, a very large government grant, to do a multi-center 15, you've all seen some of these, of 15 different institutions. We'll find out in the next month, but they're all going to be using grand aids for cardiac disease. Again, not just heart failure, but all the way to coronary bypass and stents. So we're up and running. We've got 5 starting this month. UCLA, Temple, Methodist in Houston, sort of places. And we think it's been a very, very gratifying thing because it makes sense. It's just taking somebody, taking them at home, helping the patient, helping the family, not in any way to say we shouldn't use technology. We should use technology. Every patient doesn't need one of these. So we have to understand better in each country who does. Who is it that needs a grand aid? Who can just get a phone call? And the phone call is fine, and they do just fine. Some people maybe just need an app to remind them to, eat less salt. So one of our real questions moving forward is we don't want to have grand aids for everybody if they don't need them. We know there are some that do, and fitting in to what you're already doing is what's sort of the most fun of saying, okay, you do this, how can we help? Recognizing it will have to be a INCR program, not even a Madrid program, certainly not a Scotland program. And that's what's fun about this. So I think I will stop there, say thank you very much. I don't see anybody asleep. Most of the people, it's very difficult to sleep standing up. I've done that at an operating table. It's tough, but I've done it. So thank you very much. Happy to answer questions.
Voy a open. ¿Alguna pregunta?
Your studies, will be the main reason for medication alone.
Why don't they?
Yes.
I'm going to turn to Donna in a minute. I think a lot of these people just don't understand. I think and this is 2 things. It's, you'd like to think that they got perfect teaching on the way out of the hospital, but sometimes they do, sometimes they don't. But when they get home, There's a lot of confusion. So let me talk to Donna.
Why
doesn't it? Why?
What's really surprised me the last couple of weeks with this teaching I've been doing with the supervisors in the home is I'm seeing families, the daughter or the wife has decided that the patient doesn't need this pill. No, and I just can't believe almost every home with a very concerned, good, loving family member, but they've decided that mother doesn't need this, this, and this, and even had one woman that was a sister and also a retired nurse say that she didn't need the Lasix, water with lemon juice was better. And this is a heart failure patient. So it's...
We should try that.
And then patients are discharged earlier, so they're sicker when they go home.
I have an additional hypothesis that I think, to me, is very interesting. We have a grant from the government with Methodist Hospital in Houston, the Big East Old Hospital. And it is to reduce readmissions in patients with delirium, specifically patients with delirium. Now, in their population, 40% of every patient over the age of 70 that goes home has delirium. And this isn't just heart failure, this is everything. This is hip replacement. So a lot of people with delirium. Clearly, delirium is a risk factor for readmission. But I think that the caretakers who have been sleep deprived, so, Mary is in the hospital. Carlos is at home, but is traveling back and forth and maybe sleeping on the floor next to Mary, sleeping in a chair. The caregivers are sleep deprived, and the caregivers are anxious, and there may be confusion in that first week, organic confusion of the caregivers in addition to the patient. We don't know that, but so that could contribute. Some of these people, we've had the experience of a very experienced nurse, a cardiac nurse, who was telling us that her husband went home from the hospital with heart failure, and after about 2 weeks, he looked up and he said, I really don't know what medicine I'm taking. This is after about 2 weeks. This is an engineer. So it's not necessarily intelligence. I think there's some organic things going on with both patients and caregivers, and who can remember to take 12 medicines. So I think there are myriad reasons, but whatever they are, the idea of a person in the home who every day is there saying, all right, let's make sure you're taking your medicine, let's make sure that you're not just drinking water with lemon. And this seems to work. There are a lot of different reasons. But and again, I think, I don't know here, a lot of places in the world, it's medication issues and salt issues that get you readmitted in that first 2 weeks.
How do you recruit people from care? Between relative or outward terms?
So there's two kinds of recruitment, right? There are the nurses, there's the supervisors. The key to this is really the nurse. The key to this is because the nurse sets the tone with the grade aides, with the remainder of the staff, to say this is a great program and let's all work together to make it work. So the key is really, the first recruitment is the nurse. The nurse then has a number of places that the nurse can go to recruit grand aides. And again, it depends on what level of person you're looking for. If you're looking for somebody that is an auxiliary nurse, for example, there are hundreds of them in the hospital, right? Hundreds of them, whether inpatient or outpatient. there are people that work in nursing homes who hate working in nursing homes and who would love to have an alternative. And these are people that, you know, have taken care of patients. We're not talking nurses here, we're talking lower level people. And so between nursing homes, some of the home health agencies, and the hospitals themselves, generally, you know, if you start with a pilot of what we've seen around the world, is you start with an announce, we're looking for 10 grand aids, you get 50, 75 people showing up. As long as we describe it well, people love to do this. We don't have to pay them more than they're making now, as, you know, if they're working as sort of an auxiliary nurse. The job is more fun. The job is more satisfying. So we don't have to pay them the differential, and it may be different. The real issue is the nurse.
What is a little bit family medicine?
As
In your opinion, the best doctor for to...
Oh, I'm not going anywhere near that. I think the answer is that's not, the Grand Aids program is between a nurse and the Grand Aid. How the nurse interacts with whichever doctor, we don't change that. Okay, so that the nurse will communicate with whichever doctors she or he is told to communicate with, can be both primary care or
And in most
cardiology.
cases, it is both.
Yeah, we sort of stop there and don't want to change that relationship, however it exists well or less well. But what we have found at UCLA, with 31, so there are 31 different physicians at UCLA that the supervisor has to relate to. They have 3 supervisors. What this has done is it has caused a regularization of the communication, meaning the supervisors now say to the cardiologist, okay, and the supervisors work for actually a combination of internal medicine and cardiology. Who do you want, you know, to the cardiologist, what do you want us to call you about? To the primary care doctor, what do you want us to call you about? And they have a little form on your iPad that by doctor, therefore by patient, how they want to be communicated with. So it actually has potentially, we're just starting, improved some of the communication because somebody asked. But we try not to get in the middle of that.
Thank you. It's been a pleasure to have you here with us.
It's a pleasure to be here. Thank you.
Probably he will be next year because I think that he's going to fail the Taya cooking exam again.
I hope next week.